So I'm just going to assess him posturally by visual analysis, so to speak. And it looks like his head's fairly level. A little rotation in his torso, his left shoulder slightly low. And his pelvis may be off a little bit. So just visually I can see there might be a couple things off. Line your back. And he did just have a fall or something like that. Did you have a fall? Did you actually fall?
I tripped.
You tripped, yeah. Straighten your body out. You look a little torqued. No, now I want you to kind of at this direction.
I see. Sorry, Doug.
Yeah, there you go. And his pelvis did get tweaked. His left leg's short. Okay, so I always assess people initially with a straight leg test because it's convenient and most people have strength in the leg. So if I tap him on the leg, I'm going to have him raise his leg up and push up into my hand. Then I'm going to go up that conception vessel just like that, push up. And for him, it doesn't activate. That should make him go weak. And when it doesn't, we know we got to figure out the first layer of his maladaptation. So we'll have bend this knee, put the foot on the table. We're going to use this arm as an indicator, pull up that way. And pull. Put that down. Bend this one here. Pull. So either of those are possibilities. They could have been the reason why that's not happening. But as I have him kind of get in this position here. Pull. So when he gets left convex like that, it causes the weakness to show. So we know that's how he needs to get unscrewed up. You have to unravel him there. So turn over face down. What I did is I went up his conception vessel, and after I got him in a left convex position, convexing his spine to the left, he all of a sudden that conception vessel worked. So he inhibited it like he should. So we knew that's going to open up the communication system of his body. And that left convexity relates to this ligament right here, the sacrotuberous ligament, which is just medial to the coccyx. Yeah. So I go to the right sacrotuberous ligament, push, nothing happens. But I go to the left one, causes a weakness. So I'm going to put pressure on that ligament and breathe in, breathe out, and breathe in, breathe out, and breathe in, and breathe out. And breathe in. Breathe out. And breathe in. And breathe out. And push. So if I go back and challenge it, doesn't weaken. Keep it like right there. Since he's in this position, I'm just going to challenge his sacrum, see if it's in place. And it's kind of goofy. Let this come like this. So I re-challenge the sacrum after I corrected it. Push. It doesn't show anything. So two hand. Oh, never mind. So I'm going to challenge the sacrum like that, and push, and push. Both your knees bent, pull your feet together. So I'm testing the bilateral, since I've got it in position, I'm just testing the bilateral piriformis to see if there's a coccygeal problem. By testing piriformis muscles, and there's not. So now I turned him back over on his back so that I can see if I opened up the communication systems in his body. So pull it that way. So now the conception vessel operates like it should. Pull. If I go down, it goes strong, goes up, it goes weak. So we know his body's communicating now. He's going to touch K27 like that. Raise your leg and push up. That's not an issue. And there, one there, one there. And push up. It's not an issue. Cool. So relax that. So now I've kind of just come to his head to palpate his temporal sphenoidal line. Let's see if anything stands out. It looks like possibly a little muscle pattern over here might be there. So we're looking for a muscle that's weak in the clear. Arm straight and push towards my chest. And when he initiates the test, you start pushing first. And he can't win. We know his brain's not connecting to that because his upper motor neurons of his brain should be able to make that muscle strong. So we know this is assessing upper motor neuron issues. So now chew and push. And chewing strengthens them like it should. Turn your head to the right and push. That strengthens like it should. Head straight. Touch right there. Push. Don't bend the elbow. Okay. Touch right there. That's good. And those are for your immune circuits. Those are not an issue. Bend your left leg, put the foot on the table, and push towards me. And that's the pineal. It doesn't show. And this one here. And push this way. So when you go to the right gate on him, it goes strong. His pineal gland was good because the left gate didn't have an influence on this muscle weakness that he's got. But when I went to the right gate, it went strong. So it tells me the pituitary is the most probable problem with that issue. So I'm going to have him contact this little point here, and another point, couple point with the adrenal reflex right there. And I'm going to touch that, have him raise his leg up, push up, and it causes him to go very weak when he does that. So he's going to continue to touch those points as I come up to his mastoid processes. Have him breathe in, flex his toes towards the nose, breathe out and go down, breathe in and come up. So he's going to vector pump for 30 times this time. So we're just pumping cerebrospinal fluid through this motion we're inducing in the cranium to stimulate the pituitary gland. And he's got his contacts on those points of the reflexes, which conducts the energy through those reflexes, pituitary and adrenal. When he flexes his toes towards the nose, it stretches the dural membrane, which is the membrane that goes around his brain and spinal cord, and is attached to the entire interior surface of the skull. So he's actually helping do this cranial motion that I'm inducing through the mastoid process of the cranium. And he's just adding some juice to it. So now I'm going to retest that pattern that we found earlier, push up. The test's totally strong. So that's cool. So we can take the hands off those reflexes. We're going to go back to this muscle here, the pectoralis sternal, and push towards my chest. And you still got some issue there. So bend your right leg and push towards me. And that's okay. So that's not part of the equation anymore. So give me your arm again. Flex your head up, eyes down as far as you go, and push it. And when that goes strong, you can see that his sympathetic nervous system is hyperstimulated. So turn over face down. So we're going to do something to stimulate his parasympathetic.
Go ahead.
So the challenge that we just induced in the body indicated that he has a sympathetic nervous overstimulation. The fight and flight reflexes in this system are strong. And he's stuck there a little bit. So I'm going to challenge at his coccyx, bend the knee. We'll find there's an issue right there. So that coccyx and the cervical spine need to be approximated like this. So as I approximate that, he is down there breathing, and I hold that for a few moments. It induces a parasympathetic engagement. So it turns on this parasympathetic nervous system. Good. And now I'm going to retest that coccyx and push. Long time. Turn over on your back. Okay, we're gonna now retest that pectoralis sternal muscle we found was his indicator muscle in the beginning. Push. And his arm straight. And it's totally strong. So I'm going to make sure it's strong by challenging it. A little bit of energy up here. And push. And it stays strong. So now I have his supraspinal issues, which comprised of an adrenal stress pattern, oversympathetic activity in his nervous system, and that was it pretty much. So that was kind of causing a disequilibration between his brain and his body. Pull up that way. So as I test his structure, I can see his pelvis has got twisted, and his diaphragm's not working as well as it should because it goes along with the pelvis, and the first rib's off. So now we got his brain connected to the body in a harmonious way. So he's got some integration. Now I can assess his structure. And the first thing I find out, he had a short leg on this left side, which correlates with the pelvis being off on this side, which is assessed by that information, right? As PSIS, which is just on his pelvis here. If I come to this side, he stays strong. If I go to that side, he goes quite weak. If I go to the diaphragm, he goes weak. And the first rib goes weak. They all go out together. So I'm going to take these blocks. I'm going to use gravity to assist us, bend this knee, and push up a little bit. And that's going to detorque the pelvis on a mechanical basis. But we're going to go neurologically and contact these points on his skull. First point makes him weak, second point strengthens him again. And the third point, if I had another hand to test, would make him weak again. So now vector pump again for me. There's a series of connections to these points, different structures. Just travel to them. So this interaction between his vector pumping and my contacts are what kind of conducts the energy of this correction that's taking place through his cranial sutures to those different parts of his spine. So now if I come back to this, what we assessed before, it was all weak before, now it's all better. He made neurological corrections from his brain down, and with the help of those blocks as well. But it's really that neurological component that is the most potent part. And I'm just going to kind of get his lower extremity in the flow with the pelvis being in the groove. And like this. Take these guys out of here. I'm going to go back and recess the pelvis since I've got the blocks out of there, and it's all good. So now I'm going to come down and test his psoas muscle. This is classically what after I do this. And his psoas muscles are weak. And the psoas muscle, rotate like this, is the only muscle attached to the front of the lower back. Push up. And it's bilaterally weak in him. So stick your tongue out to the right. Push. As soon as he sticks his tongue out to the right, he goes strong. Stick your tongue out to the left. Nothing happens when he does that. So that indicates to me that he has an occipital fixation. So when the occipital bone gets stuck, the low back muscles, the psoas muscles, go weak. So I'm going to just come up here and contact the points to make a correction for that psoas muscle, and he's going to vector pump. So I just made a correction on the occipital bone. We made it. It's really between the two of us. And push up, and now his psoas muscles, which are again really essential low back stability, are both nice and strong now. Push down top of your head. Sometimes gravity has a factor on that, and his doesn't. So it doesn't reestablish that weakness. So now straight up like this. So now I'm going to use this straight leg test and assess his spine. Eyes up to the right. Eyes up to the left. That's the atlas. Turn your head to the right. That's C2, the rotation. Turn your head the other way. And a C2 on the right side's out of whack. That's straight. So we can very logically assume, push up the corner ceiling, that tensor fasciolatum is not going to work. And equally logically assume that one's going to work just fine. Because the C2 and the L4 always go out together. So I come here and contact these points on the suture of his skull, related to C2 and L4. Those points I've got contacted. He's going to vector pump again. So our synergized forces right now are actually working through his nervous system to adjust those two vertebrae from inside out. Good. So now I come back down here to the tensor fasciolata, which raises L4, push up, 100% strong. I stimulate that area's the sclerotope for L4, and it doesn't show any need for stimulation. And turn your head to the left, and push up, and C2's grooving. So now we're going to have him tilt his head like that. That relates to the third cervical. Push up to the sky. And tilt your head like that to the other side. Third cervical's happy. Put your head straight so we don't mess with it. Pull up that way. I'm going to put on this one. C7. That way. That's C6. Pull up that way. C5. Pull in that way. C4. Give me the start. Push towards me. C4. pull it that way, C5, and pull it that way, C7, you can see how weak that is. That's not working so good. And C6, so C6 and C7 are compromised on the left side. So you're going to open your hand, those abductors relate to C7. Turn your head this way, push open. Turn your head the other way. Head straight, and go back that way with your wrist. And this relates to C6, go turn your head to this side again, pull. So both those vertebrae need to rotate in that position. So I'm going to do a little manual adjustment on this. You could also do it through the cranium, but it's quicker and easier for me to do this. So now if we go back and after making that correction, C7 and 6, all of a sudden his shoulder works like it should. The expression through his hand is 100%. Go back that way. Good. So I'll come down just to kind of give a little sense of, see if he has any compression of his low back. And he does have some imbrication of that lower spine on the right, on the left, I mean, and on the right, so bilaterally. Cool, so what I'm going to do is I take these blocks, I'm going to use it as a lever, so to speak, put them under his lumbar spine there. And I'm going to kind of access the slow twitch aspect of these muscles and just do about 10 or 12 slow tractions, which helps the muscle kind of get into the receptive state. Then give him one of those. Push out the side, which de-imbricates that spine. So we de-imbricated him on the left side, the side. Now we're going to do the right side as well. And push out the side. So I just de-imbricated his lumbar spine. So now when I challenge to see what happens to that, he stays strong. Push out the side. And we've already tested it so awesome. I'm going to test it one more time. Push up this way. Working fine. Turn over face down. So now we're going to roll him over. So what we've done is in the prone position, in the supine position, we got his gamma 2 muscle weakness is working by unraveling certain things related to his glandular system and his sympathetic nervous system being overstimulated. And then we worked on his pelvis, got his pelvis, his L4 and C2 back in the groove, and C6 and C7 on the left side. Right, so now his spine's in, so now I'm just going to turn him over and check him out from this position. Bend the knee and push. And I'm going to challenge his pelvis like that, because that's often when the category 2 is bent there, when his pelvis is off, he's often what's called a category 3 as well. So when I challenge the ischial against the lower lumbar spine like that, it goes very weak. So we know that there's some torsion. So this torsion develops when the pelvis is out of whack. It puts pressure on the disc. So I just challenge him in the position, in the direction I need to do that. So I'm just going to put these blocks here and see if that's the position I want, which will be indicated by push-up, him going in to the muscle weakness right there. That tells me that's the right place. So now I'm just going to do a little traction on his spine as those blocks are unraveling him. And then I'm going to test him for some trigger point activity by pinching and push and push. So when I pinch along this right side, these muscles, and there's a response to that, a weakness that those muscles have a certain type of trigger point in them. Bend here and push, which is absent on the opposite side. Usually you're not going to have the same kind of muscle activity going on opposing each other in the classic example like this. So all those muscles that that weakened to the pinching activity, they have a trigger point in them that responds to percussion particularly. So I'm going to percuss these this chain of muscles. which helps those muscles go back to neutral, so they're not trying to compensate for him being screwed up. These muscles that I pinch and that cause weakness, they're stuck trying to fix something they can't, but they're stuck in a pattern. So if I didn't assess these and kind of correct them, it's very possible that they would induce an induction to the same pattern that he's emerging from. So we're just taking these muscles back to neutral. And percussion is the one thing that actually causes these neuromuscular cells to respond. Somebody figured that out somewhere along the line. I'm just going to stimulate a little percussion at C3, which helps rebalance the whole neuromuscular system to its new option of being in balance or not. Into L3. And this little reminder to the SI joints. Cool. So what I'm going to do is I'm going to reassess the things. I always reassess everything I fix. So I'm just going to go back and do the same thing I did a moment ago. Push it here. I'm going to pinch his butt. Hold hard. Hold hard. Hold hard. And hold. And now they don't weaken anymore. Even this one here. I'm going to do just a little traction like this along those muscles there. Push. And if he needed a fascial issue, that would weaken him. So we just need to treat that side. And then we're just going to have him test this couple muscle patterns to see if there's any spinal fixations. Like this. And push your elbows towards the sky. Okay. And they're looking fine. And bend here. Elbows up towards the ears. I'm going to go down this way. We're looking good. Cool, man. So I'm just going to traction just a little bit more as things are balanced. Get these guys out of here. So now I've kind of already worked on him in the prone position. He doesn't have any more fixations. Spinal muscles are balanced. Everything's looking good, so I'm going to have him turn over on his back. And first thing I test to see if these guys here are working like this. Arms really straight at the elbows and pull up that way. Breathe in deep. Breathe out. So if there's a weakness there, I know there's some thoracic correction I need to make. That's looking good. Bend this knee. Pull in that way, I'm going to pull this way. Raise your left arm to the sky. So when he's in that position, there should be an inhibition of that piriformis muscle weakness in his hip. Because when we walk, the muscles need to turn on and turn off according to their positioning and their function within the gait. So he's not doing that very well. So we're going to unravel him, pull it that way. So I'm going to assess some things in his cranium. As soon as I go to that frontal bone and that sphenoid, he goes very weak. So when I contact into his sphenoid bone on the left and his frontal bone on the right side, like this, and so those points have to come together. So I'm going to kind of unravel his head a little bit. Breathe in. Breathe out. Breathe in. Breathe in. Breathe out. Breathe in. Breathe out. I did just wash my hands. Open the mouth. Pull it that way. So I'm going to go inside his mouth. And breathe in. So the way it reveals itself. Breathe in. Breathe out. So I'm asking the body how it wants to get unraveled in the skull. And watch this cruciate open up on the left side there. Then we're going to go inside here like this. Pull. Up here like this. Pull. And breathe in. Breathe out. 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 And one more. And pull it that way. Put your arm down, lift your head up into my hand. And let yourself roll up like this. And let it roll back, segment by segments, like that. Let it roll the same way. So we're really unraveling his dural membrane by doing this technique. Cool. Now bend this knee. Pulling that way, I'm going to pull this way. Raise your left arm to the sky. So now that piriformis inhibits when he gets in the gate position. So we know his nervous system's communicating. Push, raise your right arm to the sky. Cool. So we got his gate in the flow. So now after we unraveled his dural membrane with that cranial adjustment, cranial sacral adjustment, we know that he's not going to walk, his nervous system's not going to walk itself back into its own old patterns again. And I'm going to make sure his feet are okay because he was complaining about injuring his foot. Hold the foot back and the large toe up towards the shin. Neurologically it tests fine. It hurts him, but the nerve works fine. Relax this. Push out the side. 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 Try that again. So I found a bit of a subluxation in his foot there. Push out the side. Push out the side. And push out the side. And push out the side again. Push up to the corner of the ceiling. I was just challenged. I didn't find much on his foot. I found a little subluxation in his foot. Not even where he injured it, but that's where I found the subluxation. So I just corrected it. I've just come back to just for my own peace of mind, realizing that all that's working perfect. Now sit and face that direction for me. I'm going to assess his upper trapezius. The sitting position is kind of the last thing I do on bodies, generally on the way out. Push. And when I try to turn this muscle off on the right side, it doesn't inhibit. So we know that this muscle on this side isn't turning on. Because anytime you got muscle 2 yang, you got something 2 yin on the other side. And that's a perfect example right there. Elevate the shoulder to the ear and the ear to the shoulder, nice and firm. So we're doing a treatment to the proprioceptors of the muscles, basically. Telling the muscles to get back into gear because they kind of slipped out of gear as they compensated for how he was kind of tweaked. Good. And then this is going to come out like this and push up that way, which makes that work better right away. And when that works better right away, this will inhibit like it should, just like that. Like that. And push up. Cool. And he's about done. Cool. So Jordan just came in and kind of had an injury. He had a trip, it injured his foot a little bit. And so we just assessed him and found that he had a a pituitary gland issue. Adrenal stress pattern and oversympathetic nervous system. So his stress system has been under a lot of stress. So that's why he's kind of in that sympathetic state. So we kind of corrected all that stuff. And then we assessed his structure, which his pelvis was out of whack. His left SI joint was off and his diaphragm was compromised and his first rib was out. Along with his second cervical and fourth lumbar and his fifth and sixth cervicals. So I just corrected all those guys out, and then as we turned him over the second time, we just assessed him structurally. We saw that there was a compensatory muscle pattern on his right side, which was trying to adapt to all this stuff. So we used a percussor along all that area, so reset those muscles back into a harmonious pattern, so they're not trying to adapt to something that doesn't exist anymore since we corrected him. And then when we turned it back over, we found his gait wasn't working, so I did this cranial sacral adjustment on him to unravel the dural membrane. So now his gait pattern is piriformis inhibit when he steps forward with the appropriate foot and so forth. And then in the end, we had just a little bit of upper trapezius imbalance, where his left upper trap wasn't firing and his right upper trap wasn't turning off. And that's kind of it in a nutshell.